Alexa, what do you think?
I think we're getting started.
Great. So welcome everyone to our Clinical Culture and Diversity series. This is developed for cross-cultural competencies. And today our presentation is Guatemala Healthcare System. With the Clinical Culture and Diversity series, we offer 4 presentations through the year. There'll be 2 in the fall and 2 in the spring. And Alexa has provided our program dates. So today is September 19th, November 14th, February 20th, and April 16th. So thank you. We say that developing cross-cultural competencies improves patient care, provides individuals with a comprehensive educational experience, and helps KUMC become a more diverse and integrated campus. Students, faculty, and staff are invited and encouraged to contribute to the conversation. We are offering continuing education credit. So please check to confirm you're signed into Zoom with your full name, your first and last. This is how we can confirm your attendance. So after you sign in, if you need to change your name to display your first and last name, click on the Participants tab at the bottom of your screen where you see the other meeting controls, and you can rename yourself. They need this for the attendance log in order to assign continuing education credits. Here is our statement for our series and our conflict of interest disclosures. So for those of you who want to obtain continuing education credit or a certificate of attendance, this is the continuing education credit sign-in code. This will also be provided in the chat, and it will also be emailed after the presentation. So at this time, I'm going to introduce our speaker today, Dr. Francisco Mendez. He holds an MD, but also a master's in public health. He's a good friend of ours, a good friend of KUMC, and we're really happy to have him here today. He's been working for over 25 years in clinical practice, health administration, and education with medical and non-medical students. He obtained his medical degree from the University of San Carlos, Guatemala. He completed an internship at the Primary Children's Hospital in Utah, and he received his master's degree from the University Rafael Landívar in Guatemala. Hospital San Pedro is a 10-bed hospital in the rural area of Guatemala, founded by Dr. Mendez and his wife, and with the support of donors, is what enables him to share his knowledge and expertise and to contribute to the learning process of students. Dr. Mendez is the medical director at Hospital San Pedro and is responsible for the management and all administration. He trains local and international students and volunteers in healthcare education and provides them with intercultural activities. Since 2018, Dr. Mendez's clinic at the Hospital San Pedro has been the clinical site for the University of Kansas Medical Center International Outreach Organization, KUMCIO, their first and second year medical students, as well as for many of our residents at KUMC. So with that, I'd like to turn the microphone over to Dr. Mendez. Welcome, Dr. Mendez. Thank you for presenting. I know you've had an opportunity to present several times to our community. We always enjoy your information, so we appreciate your time.
Thank you. Thanks for the opportunity. I always enjoy sharing our experience here in Guatemala with all the students. And I want to talk now a little bit about the health system in Guatemala. Probably some of you already have information about the document, and I really like it because was written for not for the government, because sometimes the information from the government have some missing information. So this is very objective report. and basically includes information about the health system. The first picture of the presentation is just I wanna just try to explain then the area where we are working. It's in the highlands of Guatemala. I always say to students that I feel like I am in vacation the whole year, because the whole year the weather is just fine, just perfect, not too cold, not too warm. And I really enjoy working here. So the hospital, it's around the Lake Atitlan, and we are working in Mayan communities where the people speak 3 different dialects. The name of the dialects are Sutuil, Quiche, and Cachiquel. Some of the people can speak Spanish also, but mostly of the people just speak the dialect. In this opportunity, we are going to talk about the demographic trends, the epidemiological profile, reproductive health and family planning, maternal mortality, and child health. This is what I want to focus this presentation. In Guatemala, the population indicators, which is in the next slide, next 2 slides, the population indicators, it's showing at least 15 million population in the last survey. This is information from 2000, and the population is 15 millions. The total fertility rate, it's 3.8. This have been changing from the last 20 years, and it's decreasing the total fertility rate. When I start my practice, this fertility rate was close to 6. So now it's decreasing to 3.8, which is the average of child for each woman. The population, it's growing annually between 2.5 to 3 percentage. And the next data, it's very, very important for the students. Then the rural population in Guatemala, almost 50%, it's rural. Basically, the half of the total population of Guatemala lives in the rural area. So this is the information in the next slide. And what we see that it's very, very common among the countries in Latin America, it's that the population is very young. So it's at least 40% of the population is below 14 years old. So that means that it's a very, very, very young population. So, and the elderly population, it's less than 5%. This is the information from the next slide. This is just a resume of the indicators of Guatemala. One important thing to mention in the health system of Guatemala, and it's the graphics from the next slide, please. It's the use of contraceptives. This is a very, very important program in Guatemala, and it's making a lot of changes in the population growth, the access to contraceptives. But when we split the information between the rural and urban population, we can see a very important gap. Then the family planning services are more accessible to urban population. So you can see here then from 1987, the 43% of the urban population have access to use of contraceptives, and only 14% of the rural population. These have been changing like every 5 years when a national survey was conducted, and every 5 years it's increasing the access to the population. But when you see in 2009, the use of contraceptives in the urban area increased from 43 to 66%. That's big difference. But between the rural area was increasing from 1987 from 14 to 46 to 2009. So that's still a gap between the two areas. And many researchers are showing that this is because in the rural area, the population doesn't have access to family planning, and also the education is very low. So less education the families, or especially women, have in the rural area, so less access to contraceptives. And many researchers, not just in Guatemala, but in other countries, are showing that the access of contraceptives decrease the maternal and child mortality, and also have an impact also in poverty. When families have like more than 6 or 7 or 8 childs, so the level of education and malnutrition is more common between the families with more childs, and this is a big difference in the rural area. In the area where we are working, in the lake area, this is the family planning is changing very slow, but at least it's changing. It's not in the same level like 20 years ago. So in San Pedro, which is the Mayan community where we have running the hospital, every year more women are accepting and asking for family planning services. And the most common contraceptives among those families, those Mayan families, are injections. They like a lot of injections because offer privacy to women. We have injections for 1 month or 3 months, and also we have in the community also available the implant that needs for 5 years, and also more women are accepting IUDs, and the tubal ligation or vasectomy. It's not well accepted, but it's increasing more the tubal ligation than the vasectomy. Vasectomy is not popular among the Mayan men, but these changes are very important, especially in San Pedro, because every year more families are accepting and using contraceptives. This is one of the biggest difference than we are we can see in our communities. In the next slide, we can see the maternal mortality, and and you can see also that the big difference between urban and rural area. In the rural area, mostly live indigenous population, and mortality rate, it's 159, and in the urban area, it's 70. So in the hospital area where we are working, since we start working like 5 years ago, we didn't have any mortality. So our mortality rate in the hospital is 0. But we have some complications that we are dealing in this hospital. Actually, in the last month, we have here one of the residents from KU, Dr. Rebecca Yan. At the time that she was working in our hospital, we have a young woman coming from a community with a severe bleeding. After delivery, a baby in the community, the placenta was, the midwife couldn't remove the placenta. And the ambulance bring this patient to our hospital with a severe bleeding. She was basically in shock, but thanks God, we provide the medical support to help this woman to remove the placenta. And this is one of the successful story that we have in our hospital since we start. So we are receiving a lot of complications from our communities, and we can tell that since started the hospital here start working the hospital here in San Pedro, we was helping to save lives, especially for women with bleeding, which is one of the most common reasons of mortality here in Guatemala and other countries also. So the next slide, it's showing the main reason of maternal mortality. It's severe bleeding, which we have a lot of here in our hospital. Infection also, it's very common, and hypertension. This is the 3 main reasons of having complications here in the lake area. And in the next slide, we are just showing an example of what it's the picture in the lake area. The mortality rate, it's very high, and probably Guatemala have one of the highest mortality level in the whole world. Probably it's just similar to Haiti or some other countries in Africa, but it's really high. And 60% of births happen at home with a midwife. Midwife in Guatemala, it's very, very important health provider, especially in Mayan communities. Most of the people get their prenatal care with a midwife, and 60% of the prenatal care have their births with a midwife at home. So in last year in the lake area where the hospital it's working, we had 23 women who died during delivery or after delivery. So that was the number from last year from the whole area, where we have actually one public hospital, which is the biggest public hospital in the area, with probably 1,000 beds, but we have this facility, but still the mortality rate it's high in the region. Another important problem, health problem in the area, it's the teenagers' pregnancy. The teenagers' pregnancy, it's been increased in Guatemala. Actually, in the last 2 years, since started the virus, coronavirus outbreak, the teenagers' pregnancy increased. And we have this problem also in San Pedro. When we have some emergency in our hospital, mostly of them are young women. Sometimes we have young as like 14 years old. And also in our hospital, it's doing between 4 to 5 C-sections every month, which is not good in terms of we should be having more normal deliveries in our hospital. But when we consider that it's like a referral hospital where mostly of the surrounding communities are sending patients to our hospital, and sometimes they are sending when they have any complications. So it's understandable that we are having more C-section than the normal deliveries. In the next slide, this picture is it's showing a midwife explaining her job, her responsibilities in the community to the resident from KU. This is Dr. Rebecca Yan. She was working here in our hospital last month. And obviously we try to encourage this contact between midwives and our doctors here, because it's a good way to understand what they are doing in the community. And also for public hospital, we think that this is one of the barriers that public hospital have, because they are not too open to work with midwives. There is a barrier between public services and traditional medicine. And in our hospital in San Pedro, we try to open the doors to midwives. So we try to be friendly with midwives. So in order that we can get their confidence and they can bring their patients in an early period, in an early stage, because sometimes when midwives don't want to take their patient to a hospital, it's because they feel that they don't have, or they don't feel the confidence to doctors. One important thing that we try to do also in our hospital is to speak the dialect. The 90% of the midwives, they just speak the dialect, the local dialect. So we try to make our nurses or doctors to talk the dialect with midwives and also with patients. So this is a very, very important experience for our students. Then we try always to involve our students here in the hospital, or residents or volunteers. We try to involve them to traditional medicine, to talk with midwives, with traditional healers, with shamans. So that's a very, very important strategy for us to in order that we get a good connection with the community. In the next slide, I'm showing this is in Spanish, but I will. I know that some of you can read Spanish, but I will try to explain this slide. This is what the Guatemalan map. In the north side, it's Mexico, and in the south, it's El Salvador and Honduras. And this is showing how many teenagers have a pregnancy, and it's more than 67,000 childbirths between teenagers. I mean, age between 10 to 19, and the highest level it's in the north region of the country, and in the lake area, which is Solola. We had in 2022, last year, we had 1,289 childbirths between women between 10 to 19 years old. So this is basically showing the magnitude of the problem, the public health problem of pregnancy between teenagers. Basically, this is in the next slide. It's showing like briefly what I was explaining in the first slide. So this is the worst condition in the rural area. It's basically the characteristic. It's like we have high maternal mortality rate. Also, the neonatal mortality rate, it's very, very high, and also this is one of the most serious problem that we are facing in our work every day. And basically, this is what I have for the presentation today. So I am open to any comments or questions.
Thank you so much, Dr. Mendez. We really appreciate you giving that overview of your clinic and the population you serve, specifically relative to women's health. What questions do we have at this time? Anybody have a question before I throw one out there? Dr. Mendez, can you elaborate a little more on your work? I know you work very closely with the the Mayan healers and other individuals in your clinic, in the community health workers, midwives specifically related to this particular topic. Can you tell us a little more about how you interface with the midwives, like what that might look like on a daily, in your daily schedule?
Yeah, we have in this, we include in the staff a midwife, and basically we work like a team when we have a woman in labor. So we try to leave the cultural issues to the midwife, and obviously, since I start my practice more than 25 years ago, I also learned that there is a lot of things that we can learn from midwife. When I finished my education, one of the things that I used to do to deliver a baby, especially when it's the first baby for a woman, I do episiotomy. This is like a routine in a public hospital, and that was that's something that I learned. But when I started my practice, I was noting that the midwives, they don't do that. They just let natural, and they don't do the episiotomy. And then at some point I decided not to do episiotomy, and I think in the last 20 years I didn't perform any episiotomy, only in a very few and specific cases when it's very indicated to prevent any other complication. But I learned this from a midwife. So in this point, so we can see that many hospitals also, including in the US, are trying to keep in their practice something that we call here medicina basada en evidencia, evidence-based medicine.
Mm-hmm.
Yes, so this is something that we are doing a lot here. So we try to learn what they are doing in the right way, midwives. So we are open to learn from that. So and in that situation, midwives feel very comfortable, because they think that when they come to our hospital, they are not like in a very low level than a doctor. So we try to exchange knowledge. So we learn from midwives, and they learn from us. So and when we have our students here also, we try to give the students the opportunity to interact with traditional healers, especially with midwives, because midwives are doing a very important job at the community, and because also it's a country priority to reduce the maternal mortality. So we try to encourage the cooperation between midwives and doctors.
So probably there's still a lot of births that are happening out in the community, right? Not everyone comes to your clinic or your hospital for delivery. Can you speak a little bit to what is that interplay between you and the midwife, and like those who are delivered out in rural settings or at home, as opposed to delivering at the hospital?
Yeah, well, at least 60% of the deliveries are at home with the midwife. And we try in some way to keep like that, because it's more accessible for the population. Right. They feel more comfortable, and it's more in a natural way. But we are having some troubles when we have some patients coming from the community, because they come too late. Sometimes when it's almost impossible to do something in a hospital, like severe bleeding, we know that in just like some, I try to explain to students this, that when you read a book in a university, a book will explain to you if a woman bleed like 1 liter or 1.5 liter, it's very dangerous for a woman. But this is usually for women that have probably a good nutritional level. But in the rural area, we have a lot of malnutrition, and mostly of pregnant women they already have a very low level of hemoglobin, so they are with anemia, chronic anemia, and bleeding just like a half liter for them, it's catastrophic. So you don't have to wait until it's bleeding 1 liter and then say, oh, that's dangerous and we have to take to a hospital. Even if it's just bleeding more than usual, so that's an indication then they have to take to the hospital. This has been a little bit difficult to explain to midwives. Then they need to they need to try to take their patients early to a hospital. And the problem also it's not just the knowledge or when to take the decision, but also there is a geographical barrier. And we are in San Pedro, and sometimes people have to cross the lake to go to the main hospital, like the public hospital. And then that's take at least 1 hour to get to a hospital with a blood bank. That's the reason also that we have in our plans in the future to have a blood bank here in our hospital. We are trying to improve. So like every year, then the students are coming, the students will see then there is a difference. I know that it's slow, the changes are slow, but we are doing improvements. We just opened the second operation room in our hospital. We are trying to have OB/GYN like every day here in the hospital. So what we are trying to do is increase the access of the rural families to the health services. So, and we consider that this is one of the best facilities that we have around the lake. So, and this is, I mean, I feel very proud of this because every year we are trying to improve, we are changing, and thanks God we have very good friends also that are financially supporting this. But we try to do our best.
Thank you. You did answer my question. It was I wasn't so clear, but I was wondering how you kind of encourage the midwives to partner with you. And thank you for that answer. And Dr. Sakari also put a question in the chat, but Dr. Sakari, would you like to ask it yourself? Unmute yourself.
Yeah. Francis, from what you've indicated, the main issues are actually problems of rural, urban, lack of health education, languages, and there are not much cultural issues involved. How much community outreaches are you doing to educate the communities concerning the complications of pregnancies, taking anti-pregnancy medications and their complications? And how does the government come in to help you?
Okay, if I understand correctly, the level of education is very, very low. So to try to educate the community leaders, community members, or midwives, we have to be very creative. So it's there is not like a way that you can just like write like a pamphlet and give to the community, because mostly of the people are illiterate, so they can't read, they can't even Spanish. So what we try to do is like interpersonal communication. We try to take advantage of some of the complications that we have here in our hospital. It's like the example that I was explaining last month, and we have with the residents from KU. So we had a meeting after that with midwives to explain then they can't wait. They only can wait probably between 10 to 20 minutes until the placenta it come spontaneously out. But after that time, they have to take the decision to take their patient to a hospital. So, and also one important thing that we are doing, it's try to educate in some symptoms or signs of high risk pregnancy, because sometimes there are some cultural barriers. It's like if we have somebody in the prenatal care, then it's a single mother have some troubles at home, not the economic or emotional support from the family. We consider that it's a high risk pregnancy, because those kind of population, their self-esteem is very low, and it's not easy for them to ask for medical care. So we try to think also like in the area where we are working, the level of poverty, it's 80%. So that means that 80% of the population survive every day with less than $1 a day. So in that condition, we consider like then a woman just staying in this area, it's in high risk. So and this is one of the very important program that the government of Guatemala are doing. The Ministry of Health have some educators in the community, and when they identified any pregnancy in the community, they try to follow up these women. They make sure that these women receive the prenatal care, and when they are not coming to a facility, a health facility for prenatal care, they try to visit at home and try to encourage the patient to visit a doctor. And this is a really important work that are doing the government. But despite these efforts, I mean, we still have a high mortality level. I know that it's decreasing. It's not the same like 10 or 15 years ago, but it's some of the important change. So in the area where we are working, education, it's very important. And education, especially to girls, it's one of the most cost-effective strategy for the country to decrease the mortality, the maternal mortality.
Thank you. I think a very quick follow-up. It's important that as a medical doctor, they respect you, they take you very high, and your instruction of the health department to do rural education in their vernacular language, the complications of pregnancy, the importance of preventive measures. I think the onus is on you to make sure they have this education in rural areas, in their vernacular languages, so that you won't have this complication. You don't have much problems of culture, disparity, or anything, but it's lack of education in the rural areas and poverty. So the health department will listen to you if you put your foot down and give them the right instructions for education. Thanks very much for your presentation.
Thank you.
And Dr. Mendez, we had a couple other questions in the chat relative to actually the language and the barriers of having many different indigenous languages. Are medical students being trained in those languages, or how do you deal with, those different indigenous languages? Is there always a midwife who speaks the indigenous language? I would assume if they're in the community, the midwife would be part of that community and speak the indigenous language, but there's just a lot of questions about that.
Okay, yeah, that's a very important questions. Unfortunately, in the medicine schools, different medicine schools, public and private medicine schools in Guatemala, the learning of a dialect or a local language, it's not an option. But I just was involved in a meeting last week here in the community, and we have some local doctors that now are from this community, and at least 3 or 4 of these local doctors, very young doctors, they speak the dialect. So when I started my practice more than 20 years ago, I was the only doctor speaking the dialect. So probably that was one of the reasons also then I had a good connection with those communities because I speak the dialect. But in schools, it's not an option. That's something that it's not.
It's just not part of the curriculum. It's just not in the curriculum.
No, it's not. It's not. Actually, should be in the curriculum also. Not just the dialect, but the learning of the traditional medicine. But that's not part of the curriculum.
Yeah. But I think that speaks to why it's even more important that you collaborate and partner with the midwives who are part of those local communities and speak the local indigenous language, as well as community health workers. So the fact that you partner is very important for the health of the community and for the individuals. So what you're doing is really good work. Your partnerships are what are important, I think.
Yeah, that's right. That's right. Yeah.
And it gives the medical students in Guatemala exposure to that as well. So in effect, when you have a medical student who's rotating with you, whether it be American, but I think it's even more important when it's a Guatemalan that they see that, because you're passing on a way of practicing medicine and not just a skill set, right? So it's a way of collaborating with others, and not just here's how we, for example, do an episiotomy, because that's not something you should do. But yeah, there are skills that most students learn when they rotate, but you're sharing a way of practicing medicine with them.
Yeah, that's right. Yeah. Well, we have here in our hospital some students coming from the local universities, private and public university from Guatemala. They had some rotations here. Yeah, I think it's good. It's good. It's very important. And I think when they what I always tell to students, it's the idea is not to understand the traditional medicine or the culture, but at least show some respect, because this is what it's, I think, one of the barriers in the public hospital. It's that the doctors, they are not showing respect for the tradition. So they think, it's something that they are thinking that it's totally different from the Western medicine, and it's not acceptable, and they have a lot of mistakes. So that they usually doctors in public hospital are thinking only on the things that then it's not working in traditional medicine.
Oh,
but
yes.
but when I try to talk also with doctors in a hospital, I say, hey, we also do mistakes in a hospital. So doctors in a hospital, sometimes we have to do some mistakes and we have to correct that. So it's exactly the same in the traditional medicine. But this is, I mean, it's a kind of a challenge. I try to make doctors in public hospitals try them to show some respect to traditional medicine. Yeah.
I noticed that Dr. Young is on the I don't know, Dr. Rebecca Young, are you able to unmute yourself? Did you want to add anything to the conversation since you were just there in August?
Hi, sorry. Yeah, I was just listening in as I'm working. Hola, doc. Yeah. I feel like during my experience there, definitely learned a lot about maternal child like mortality and complications. But yeah, I think the perspective from the midwife of, I think the trust from the community like cannot be understated. And so you can just like really tell like the community really do trust the midwives. And so it's really cool when the midwives, if they ever sense some sort of need for further surgical intervention, they will do so. But I think there is still a little bit of apprehension of going into the hospitals and things like that, just because it's just a different perception. Yeah.
Thank you. Yeah. Thank you, Dr. Young.
The dollar and the peso. There was a question on the dollar and the peso. Could you give us some answers?
The quetzal. Yes, I do have a question on that. Yes, thank you. You mentioned
she wanted to know. Yeah, go ahead, Amy.
Thank you, Doctor. Thank you. You mentioned that 80% are in poverty, and you said they're living about $1 per day. Is that $1 US or is that 1 quetzal?
Yeah, $1 US. That's
Okay.
kind of just a economic indicator for the World Bank organization. And basically, I mean, in the area where we are working, it's 80%
of poverty. And to Dr. Sakari's point about getting healthcare or the community outreach to there, I mean, you have a lot of rural areas, and I know that religion is huge. It plays a huge factor a lot also in the contraceptives. Do you find that the rural areas are opposed to the contraceptives, and that is creating bigger issues, and including the poverty issues? I mean, it all kinds of goes together, doesn't it? Or does it?
Yeah, well, the contraceptives, it's have a long story in Guatemala, and it's something that have been connected with the government. So in Guatemala, we have a civil war during 30 years, which ended only 15 years ago. And when start the contraceptives start through the government. So the rural communities didn't feel confident about programs coming from the government. Actually, they was thinking, oh, probably this is another strategy of the government to make sure that the indigenous population will decrease. So that was the misunderstanding or misconception of the rural communities. So when we start, I say when we, because I was a director of a family planning program in the country. When we start, after when finished the Civil War with a family planning program, and we start talking their language, we start respecting like the natural family planning, because was more accepted for communities. So people feel more confident about that. So, and also some research are showing that people, before to use a modern contraceptive, first use a natural contraceptive. So that
Oh, it looks like Dr. Mendez got disconnected. So I'm sorry about that. I think he was making an interesting point about natural family planning being effective and culturally acceptable. So that's probably a good route for them to take, as it works with the community and with their culture. So thank you to everyone who joined us today. We really appreciate your presence and your support of our programs, and we hope to see you on the next one. Have a great day and have a wonderful week. Bye.
Thank you.
Thank you.